I am Dr. Keith Kowalczyk. I am a urologic oncologist at MedStar Georgetown University Hospital. My patients are cancer patients that have malignancies or cancers of the genitourinary system, so that's anything from prostate cancer to kidney cancer to bladder cancer to even adrenal cancer. So anyone with those conditions I will treat. What's exciting about my job is my patients. I love my patients. I love going in, and I love, especially now having been practiced for over 10 years, I know my patients very personally, and I enjoy meeting them and meeting with their families and seeing how they're doing. So that gets me through long days very easily, as it doesn't feel like a job to me. I'm just meeting a bunch of my friends for the day and seeing how they're doing and hoping I can get them through whatever next steps we need to get through, or just catch up and say hello. What we deal with can sometimes be somewhat embarrassing for the patient. So it's nice to have and be able to have a good sense of humor and bring the patients through that with a good sense of humor. And I find that urology brings all of that together, treating patients in the beginning, operating on them, curing them, and then following them for a lifetime, and then even seeing their family members, and all at the same time being a friend to them, helping them laugh and get through it, and that's been very rewarding to me. Urology is always cutting edge, so that's what gets me excited about urology. We are always looking at the next best thing, and we are always on the forefront of technology, which is another reason why I wanted to go into the field. When I first started as a student is when we were first getting involved with robotic surgery, and now that's become commonplace. And we're pushing the limits of what we can do with robotic surgery every year. Surgeries that, when I first started practice, we were doing open, and we are now doing robotically, which gets patients out of the hospital in just a matter of days rather than a couple of weeks. And that's all because of robotic technology, and that improves every year, and that's very exciting. But we're also moving past that. We're trying to look past just surgical options to minimally invasive options where we don't have to remove the organs, where we can do what's called focal therapy, or just treat part of the organs, and part of that is having better imaging or better studies so we can see where tumors are and what needs to be treated and what doesn't. So, quality of life in urology is very, very big, and we're using technology to make our treatments much easier on patients and letting them live a long time, not just free of cancer, but also with a great quality of life. Patients with urologic cancers should come to MedStar Georgetown because it isn't just me who is going to direct your care. I am part of a team of wonderful people. I'm the urologist, and we tend to be the quarterbacks for urologic cancers, but I work with amazing medical oncologists. I work with amazing radiation oncologists. We have some of the best radiologists in the world who can help me look at your CT scans and MRIs. And we meet every 2 weeks to go over cases to see what is the best approach for your cancer in your individual case. So it's never a one-size-fits-all for us. We all meet together to figure out what is the best treatment option for you. So urologic cancers are any cancer or malignancy or uncontrolled cell growth in the urologic organs. And going from the top down, that involves your adrenal glands, your kidney, the lining of the kidney, which is called the renal pelvis or urothelium, the lining of the ureter, which is the tube that connects the kidney to the bladder itself, the prostate, which is underneath the bladder, which is only in men, the urethra, and the penis and the testicles. Prostate cancer is the most common cause of cancer death in men in the United States, and the second most commonly diagnosed cancer in men in the United States. So it's unbelievably common. It is so common that most men in their lifetime will likely develop prostate cancer. The question that we have to answer as urologic oncologists are which of these cancers need to be aggressively treated and when, and which of these cancers can be let go and watched. Now, we discover prostate cancer in generally much earlier now than we used to 30 years ago, and that's because of PSA screening. PSA is a blood test that we use to check for prostate cancer. There are not many screening tests like that for multiple other cancers, and because of that, we find these cancers very early, and the mortality or death from prostate cancer has dropped significantly since the 90s because of PSA screening. At the same time, that means that we catch these cancers very, very early, and we may actually catch some cancers when they don't need to be caught. In other words, there may be some of these cancers that will never have an impact on a patient's life, and they can live years and years and years without having to worry about prostate cancer. So we want to avoid over-treating those patients, but it is still the second leading cause of cancer death in men. So it still cannot be ignored, and we have to figure out which patients cannot be watched and which patients need aggressive treatment right now rather than waiting. And that's the challenge for me as a urologic oncologist that specializes in prostate cancer, and really anyone across the country, is helping a patient navigate that. Number one, do you have cancer that needs to be treated at all? And number two, if you do, how are we going to treat it? We know that certain risk factors of prostate cancer tend to be familial. So if you have a family history of prostate cancer, you're at higher risk of having prostate cancer. In addition, it tends to be race-based. Black men are at higher risk of having prostate cancer. So there is something in the genes that are passed down in these families that are leading to increased risks. And we don't really have the exact answer why on that. We have found some mutations, such as BRCA, that lead to increased risk for prostate cancer. So we're getting better at finding these risk factors and why. Smoking may have a slightly increased risk for prostate cancer, but not so much as a bladder cancer or lung cancer or other cancers that you hear about. In addition, obesity may lead to increased risks of higher risk prostate cancer. So not necessarily increased rates of prostate cancer, but obese men, when they get prostate cancer, it tends to be more aggressive, and that may be because of hormonal changes. Prostate cancer is very dependent on hormones like testosterone, and estrogen can affect it as well. Obese men tend to have changes in these hormones that could affect the tumor. So prostate cancer is diagnosed generally by the blood test PSA, which stands for prostate-specific antigen, in which we recommend men that have a higher risk of prostate cancer get checked every year, and that would be men with a family history and their father or brother, or African American or black men. Because we find it by a blood test, there are generally no symptoms from prostate cancer. So one of the questions I get asked all the time by patients is, well, I didn't feel anything. You know, I feel fine, but that's what we want. We want to catch these cancers by a blood test rather than by symptoms. So prostate cancer is diagnosed most of the time by PSA and not by symptoms. Once we get the biopsy result, we will get a lot of information that we'll have to digest together. And that will include how aggressive is the cancer, how much of the cancer is there, does this need to be treated now, or can this wait to be treated? If we decide that this is a cancer that needs to be treated next, we'll go through all of the options. The best option in general, and there's no black or white here, there's a lot of gray, but in general, for younger men that are healthy, the best option tends to be prostatectomy, removal of the entire prostate. That gives us the best long-term cancer-free recurrence rates, and that's why we tend to want to do that for our younger patients who have a very long life expectancy. Other options include radiation options, and that can include CyberKnife, that can include brachytherapy, which is prostate seeds, that can include the traditional radiation, IMRT, but in general radiation therapies, and that's why I'll call on my colleagues with radiation oncology to discuss those options as well. If the cancer isn't quite lowest risk, but it's not high risk, and somewhere in between. In some men, we may consider the more experimental type treatments, which are focal therapies, where we only treat part of the prostate. We don't remove the whole prostate or radiate the whole prostate, but we can treat that one part of the prostate that seems to be the problem area by either freezing the prostate or heating that area of the prostate up with microwave beams, essentially. So we do all of this at MedStar Georgetown, and each cancer is different, each patient is different, and we'll discuss all of those options to see what's best for you. Our experience has been that Retsua-sparing prostatectomy is just as effective at curing prostate cancer as standard prostatectomy, while also leading to increased overall quality of life, as well as much lower chance of having urinary incontinence.